to have over 10 episodes of convulsions despite sedation with propofol. BP 157.86 millimeter hydrargyrum, pulse rate 169, regular, temperature 39.9 degrees of Celsius. Due unsuccessful sedation with propofol, decision to sedate a patient with isoflurane was made, and as it has been recommended by available in internet literature. From 14:40 to 16:0, no convulsions observed, but at 16:40, our patient convulsed last time. BP started to decrease up to 104.47 millimeter hydrargyrum, pulse rate 150 per minute, no arrhythmias. Patient remained stable overnight and had no episode of convulsions. In ICU, next day, no fits observed. Mental status improved significantly. Sedation with aflurane was stopped at 8 o'clock. Patient was extubated, breathing spontaneously, SP200% on O2 via non-rebreathal mask. However, patient has started to have bradycardia after extubation. BP 127/71 millimeter, pulse rate 49 per minute. Immediate intervention, atropine was given and pulse rate improved to 80 per minute, sinus rhythm. By 8:30 a.m., patient was fully consciousness, cooperative, complaining of body weakness, no convulsions. Days 3 and 4 in ICU. Patient condition was improving, fully consciousness, cooperative, no fits, complaining on general body weakness and abdominal pain, stable vitals. On day 4, patient was discharged from ICU. Last vitals, BP 118/72, pulse rate 98 per minute, regular, sinus rhythm, no arrhythmias. On day 5, patient was stable and was discharged from the hospital. Subsequent reviews, patient was faring well with no complaints, vitals were stable. Neurological and cardiovascular exams were normal. On subsequent reviews, patient was able, within no complication, was scheduled for elective laparotomy under general anesthesia. Recommendations: to implement a double check system, separate storage protocol, mandatory labeling of medication, minimize look-alike vials. Toxic effects of intrathecal tranexamic acid may be reduced by reducing its cerebrospinal fluid concentration. Earlier cerebrospinal fluid lavage has proven to be effective. Literature recommends not to exceed volume for lavage of 150 mL of normal saline. Many decisions in treatment of this patient were made out of despair. Conclusion: tranexamic acid remains an important drug, and we do not discourage its use in theaters, but it is imperative that it will be used safely. It is much as we want to save lives through the use of the drug, even one death from this error is one too many. And always remember that the best management of practice is prevention. There are references. I would like auditory to look on the paragraph number 7. Lusaka Provincial Health Office recommendation, Dr. Chionga 17 of March 2025. They are concentrating mostly on prevention of accidental tranexamic acid injection. Thank you very much. It is end of my presentation. I will be happy to hear your questions.
Thank you very much, Dr. Danylov, for that elaborate presentation. And also thank you very much for being within time. So at this juncture, I'll ask for questions from our listeners. Maybe we can take 3 questions to begin with and give chance to the doctor to respond. Then we can have another set. Do we have some questions, perhaps comments or contributions?
Madam Moderator, I've raised my hand.
Okay, sorry, I haven't seen the raised hand. Yes, you can go ahead.
Thank you very much. I'm happy to attend this presentation because the inadvertent giving of tranexamic acid has been so traumatizing to all of us, even with one death. What I would like to know, are these recommendations that are coming out of this presentation, are they new? are they not already supposed to be standard practice with regards to how people behave in theater?
Yes, madam, can I answer?
Yes, please go ahead.
Yes, this is standard recommendation has been introduced for quite a long time. I first heard them in anesthesia department UTH in Women and Newborns Hospital. And I am saying that even Lusaka Provincial Health Office recommendation from Dr. Simuyanga Chionga, which has been issued on 17th of March this year, it's concentrating on this recommendation on preventions. Yes, it is not new. It's something which is already officialized. If you will send me your number, I will send you this recommendation as well in PDF format through WhatsApp.
I will appreciate that. I just was thinking that do people in theater already know that they should be double checking? They should be, I know it's a recommendation that has been given. I'm just thinking that mistakes happen because people ignore things that they're supposed to be doing. I'll send you
People
my
supposed to
number.
double check, but still accidents continue happening. People know, people were oriented throughout, and still mistakes are happening.
I appreciate it. I'll send you my number, Doc. Can I ask a second question, please?
Yes.
I saw that you did a lavage for 500 mils normal saline,
Yes.
you also explained that the recommendations say that you should not use more than 150 mils of normal saline. Please explain the discrepancy.
Yes, the point is that the second accident which I observed in my practice. It is second accident. And I know that management of such kind of patients in our ICU is extremely difficult and tricky. But that is why I decided to do a flush with increased volume of normal saline to flush away as much as it possible. So I will have better chances when I will be managing the same patient in ICU. Because I believe that flushing away of this drug is most successful way to improve outcome. ICU treatment of this patient is extremely difficult.
Do we have any other questions? We can also feel free to type the questions in the chat. For those that are not able to unmute their mics, you can also share your questions in the chat.
Excuse me, my name is Samuel Swanda. May I go ahead and ask some questions? Or I don't know whether they're questions or they're comments.
Your question.
Okay, all right. I think there are a number of things, some of them have already been highlighted, but then I think I kind of like got disarmed in my questions because there was a declaration at the end of the presentation which said that some of the decisions were made out of despair. Because when you look from the start, I know that accidents do happen, but when you look from the start, I've got this question, Dr. Mykhailo, that was this an emergency or an elective case?
It was an elective case.
Okay, then how were we starting an elective case with an HB of 8.6? I know maybe the focus of this discussion is on tranexamic acid, but maybe I just want to understand the decision-making. Why were we doing an elective case with starting an HB of 8.6?
I think it is The way how we usually are doing such kind of cases, if HB above 8 gram per deciliter, we accepting such kind of patients for spinal. Then they are doing their surgery, and we are transfusing after procedure. So most of this, and I'm sure that blood was ready for this patient, but we were planning to transfuse after procedure.
Oh, okay. I think I don't want to dwell on that. I just wanted to understand, because that actually raises a whole different can of worms. Then I think after we realized that this patient had TXA administration in the spine, we continued to maintain this patient on halothane. I think it was 1.5% of halothane. And yet we were worried that this tranexamic acid in the intrathecal space would result in arrhythmias. And yet we also know that halothane is one of the incredible inducers of arrhythmias. Is there any reasoning why we did use halothane in this patient rather than isoflurane? I know that ISO is the recommended drug, especially in this, or gas in these patients. But at the same time, just by knowing that this patient has a high risk of going into arrhythmias, is there any reason why we used also an arrhythmogenic gas like halothane?
Yes, sir. So first of all, in this theater, which we were operating on this patient, machine only with Galathan vaporizer was available, and Galathan was only drug which we had in that particular moment in this particular theater.
Okay, so it was the only one available at that time.
Was on this machine. It is only was drug which was available. And yes, actually Galathan is arrhythmogenic drug, and probably it was a not ideal solution to maintain patient on Galathan. But I am sure that patient was on ECG control. We were controlling ECG. I am sure that I was able to observe ECG during procedure. And in case if any arrhythmias will start, my first decision will be to stop Galathan. And in ICU patient was all the time ECG has been monitored.
Okay, all right. There are quite a number, so I need to just, I know, sorry for everybody who is listening. I know maybe somebody wants to ask another question. Maybe just indulge me for a moment. I hear that this patient didn't want to give neuromuscular blockade, especially while it's in theater. And then after that, you started using, I'm not sure which one you used to try to control the convulsions with the neuromuscular blocker. I'm not sure about the rationale of that, because I thought that your first line of treatment, especially in these, will be either the phenobarbitons or the diazepams, isn't it? That's what we usually go. Either we go for diazepam or midazolam. You also went for propofol. Is there any reason why you used a neuromuscular blocker in this patient? Because I'm not saying it wasn't a good thing. I thought it was going to be used for something else rather than being used to control convulsions. Because if you are using a neuromuscular blocker for convulsions, you may have what we call this non-convulsive status epilepticus, which you will not be able to see. You might have paralyzed the muscles, but then the brain itself will continue convulsing. So is there a rationale why we considered using neuromuscular blocker in this patient?
Okay, sir, you missed a point. We were not using any neuroblocators on that particular patient. We didn't use any. Only
I think if you move with your slide, there was a point which you actually say that you started using after the let me see where it is. You actually said you were using the neuromuscular blocker to try to stop the convulsions, and that's why I actually wrote it down to say that neuromuscular blocking agents will not be the ideal drugs to be used for neuromuscular blocking agents. Initially, you said you didn't use. But eventually in front, you actually said you used it. So I heard you speak about this point in the last one, but you eventually said that you used it for trying to treat the convulsions. And to me, that actually made me wonder, is there a reason why you would use a neuromuscular blocking agent in a patient with convulsion? Because you are going to stop the physical, especially the muscles, which is okay. But at the same time, you need to take care of how the brain is convulsing, because a convulsing brain is short of both blood as well as oxygen. So yes, you might control the peripheral convulsions, but then the damage to the brain is still happening. That's why I'm asking this question.
Yes, sir. Let me answer to you. On this patient, I didn't use not in any moment non-depolarizing muscular relaxant. I was just using single dose of suxamitonium to intubate a patient on the theater table. And that's all. After this, I never used not any non-depolarizing relaxant. And I totally agree with you that yes, we can paralyze the patient, we can stop convulsions, but brain stimulation will still continue, and it will cause the brain edema and permanent brain damage and death. I totally agree with you. But because we managed to flush away most of the tranexamic acid, and because we managed to control convulsions later on with isoflurane, we never used non-depolarizing muscular relaxants. And I would like to auditory to understand a way of thinking. We used diazepam, we didn't achieve a stop of the convulsions. Propofol, we've only achieved for a short time. Phenobarbital, only for a short time we were able to achieve convulsions. Somewhere on certain point on presentation, it was like patient convulsed after arrival to ICU around 10 times.
Okay.
10 times she was convulsing.
For me, I think I've exhausted on my part. I think there are others who need to ask questions. Maybe we can give them a chance.
Yes, but when we put patient on isoflurane, we had dramatically improvement of the patient condition. You see how I'm presenting from 1440 to 16 hours, no convulsions observed. But at 1640 hours, patient convulsed last time. That is this usage of isoflurane, which lead to this tremendously good effect. So I knew about it. I took anesthesia machine from the theater, and I put her on this anesthesia machine, which I took from the theater to ICU. I had another better anesthesia machine. So I was putting on this anesthesia machine with isoflurane for all night. And I was using on very low doses, first on 0.8 and then even 0.5%.
Okay.
Yes, sir. I hope I managed to answer on your question.
Hi, Dr. Michael. Can I?
Yes, Dr. Mark, nice to hear you.
Hi, how are you?
I'm
Thanks
fine.
so much for the presentation, and firstly, congratulations and well done on not just the presentation, but also successfully managing one of these cases. I know mortality across the country was very high when this happened. I guess my question is around medication safety in our perioperative settings, and what you see would be the most effective strategy in our own setting. I know there were those guidelines that were released that you also highlighted, but I wonder about how to make it practical for our setting. For example, the 2% check. How exactly do you envision a 2% check being done? Who would be the people doing it, especially in the context where anesthetics are usually done by one person only without an anesthesia assistant. So I know we usually have as a bare minimum in some places maybe the anesthetist, the person operating, and the scrub nurse, potentially a porter as well. So how would you see a 2% check being done? And do you think that a mandatory checklist, a pre-spinal anesthetic or pre-block checklist, which is mandatory in all government facilities, would also help decrease these kinds of incidents. Thanks so much.
Yes, Dr. Kalenga. So we are always doing double check. We always checking, especially now after this incident. We are checking that it's correct bupivacaine and expiry date. And when I am working with student, I am checking together with the student. I am showing to the student, anesthesia trainee, that is correct vial of bupivacaine. And I'm always insisting that a trainee will show me this vial of bupivacaine. Plus, if I am working alone or anesthetist is working alone, this anesthetist is showing this vial to operating theater nurse to confirm that that is bupivacaine, that is expiry date of the bupivacaine is well ahead. It's not yet expired. And tranexamic acid is always locked in the log of the operating theater nurse. We are not keeping tranexamic acid within theater. We are within operating room. We are keeping it not even in anesthesia room, but in operating theater nurse office. So when they need it, they are getting it only from operating theater nurse office, but not from us. We are trying not even to have even single vial in our anesthesia drawer in theater. Yes, sir. I believe in UTH, there's the same practice established.
Yes, thank you so much.
Hello.
Yes, thank you, Doc.
Hello.
Yes, I'm able to hear.
Okay, this is Dr. Wimba.
Yes.
Well done, Dr. Michael, for that great presentation. I think a lot of things have come out. I have a suggestion, considering that a lot of drugs that we are receiving now, there's no distinct packaging and labeling for specific drugs. A lot of drugs that have come in either similar or they have similar labels. They may be in the same similar ampules and so forth. Is it not fair that maybe ZMA and SARS
Thank
can
you
collaborate?
so much for those questions and contributions. Maybe
Hello?
we can take two more just in the interest of time.
Hello?
Yes, sir. You see, it is above me. I cannot interfere on such kind of issues as procurement of the drugs. As I am just accepting it is on the way as it is.
Yes, so my suggestion there, because this is being hosted by ZMA, and you being a member of SARS, and I think we are honored that you took the opportunity to speak about this. I just want to present it to ZMA, maybe working together with SARS, that we take up this at a level of ZAMRA, so that we look at labeling as well as packaging of drugs. I know the double check system, physical separation that you mentioned, and so forth are very, very important to deal with the issue at that level. But I think we also need to tackle it at another level where we regulate in terms of similar drugs, the labeling of these drugs, and so forth. So it's just a submission to ZMA as well as SARS to work together on this issue. Thank you.
Thank you, sir.
Dr. Wimba.
Hello?
Hello, are you able to get me?
Yes, I can hear you.
Yeah, this is Dr. Makenzih. It's a very good point that you've raised. I think last week we were actually working on the ZAMRA bill. I think it's one of the things that we we'll write and see how best we can handle it. It's a very good point. We'll try it right through ZMA to Zamra and see how best they can do in terms of packaging. Thank you.
Okay,
Thank you.
okay, thank you. Well done.
Maybe just as an addition to something similar. Oh, no, let me allow other people to speak. Thank you.
May I capitalize on the opportunity? So it's we're talking about the safety. We thank you, Dr. Michael, for that presentation. But by and large, this presentation brings to mind, actually, to alert each and every one of us in the different specialties that we are. Why we say so, I'll just give an example. Here we are talking about TXA, but not long ago in the past, we've had situations where drugs like lidocaine have also been swapped, have also been mistaken for something else. So literally what we are saying is most of the drugs, they are affected. And also more to that is our practice that is also in question mark. So it comes back to us as we are pushing, as we are begging on Zamra to do something. And again, on our part, also those in training aspect, the seniors, those in training, we want to see means and ways in which we can up our game as to the safety of patient care. There was earlier concern that was raised, I think, by one of our colleagues saying, is it a practice that is it not a practice that people who are working on these drugs do ABCDs? Yes, they do, but again, there may be also a miss. Why do we say so? There may be a miss, then that goes with the aspect of training. So we call upon the schools, the teachers, to up this game. It's our game. We are all in here as teachers or future teachers, as it were. We want to see how we can up our game in terms of safety checklists that have been talked about. How important is that? Which teams are put in place? Yeah, we question, is it only the doctors that should do the safety? If it's in theater, we have porters, we have maids on the ward. Are the maids also part of the system? Should they be part of this check? So we want to have a system that is indeed helping us. If only by doing so will we achieve. Zamra do their part, but also on the ground, we do our best.
Thank you, sir.
Any other questions?
Any other question?
We can
Yes.
pick a few before we move to another agenda.
Maybe just as an addition to what the others have already reiterated, what I've also found out is we have got different manufacturers of these drugs who are coming into our workspace. Today you are getting from this maybe New Pharma, today you are getting from maybe another Dart Labs and all that. So because you are used to certain brand of drugs which come in certain ampoules, because like I can tell you that potassium chloride used to come, I used to know that it comes in a clear fluid, which had a different label, but now potassium chloride looks like magnesium sulfate. So because you are used to a certain brand of coming into your area, you are likely to pick up the drug just by looking at the label. Sometimes because you are busy, or sometimes as you say 2% checks, you might be in a hurry. And unfortunately, some of us may work alone. So because of that, you don't know which drug company has now been contracted to bring in the new drugs, which may actually look very similar to the next drug. And I think as Dr. Mulenga had said, we actually lost one of our colleagues after being mistakenly being given lidocaine instead of 50% dextrose. I don't know how, if we can, the ZMA, SARS, and Zamra can come and work together and at least have a consistent supply of certain, we know that this type of drug, this color, this ampoule comes containing this drug. And at the same time, we start also implementing the 2% checks. I think that will help us to reduce the incidence of accidental drug administration, which is not warranted for. Thank you.
Thank you, sir.
All right, I think I can't see any other question. I can't see any hands that are raised. I think
Dr. Chengela.
Pardon?
Dr. Chengela was raising hand.
Okay, Dr. Chengelo, yeah, I think we'll give you a chance. You can go ahead so that we move to something else. Dr. Chengelo, go ahead.
Hello, can you hear me?
Yes.
Yeah, I think, thank you, Dr. Mek, for your presentation and to save this patient. I want to go toward the first doctor who asked a question about the practice and if this guideline hasn't been there. Yes, but what we need to know with tranexamic acid, whatever you can do, it's bound to time. As if you see the presentation of Dr. Michael, the time they discovered that tranexamic was given and the time they start acting on a patient, the time was very short. Now, in theater, most of the time, what makes difficult to treat this condition and lead to mortality is if people are not honest, and they should learn to be honest. When you know that I've injected tranexamic acid, it's better you communicate to people to facilitate the fast implementation of the guideline to save the life. As long as you can't be honest, I think this will continually leading us in mortalities. So being honest in the theater is one of the first priority when you want to treat tranexamic acid. Thank you.
Thank you, sir.
Okay. I think we are done with this. I think we'll organize with Dr. Mykhailo for the presentations that probably we can give it to people that might need it and read through and understand. So that if they have any other question, I think they can engage Dr. Mykhailo on his personal level and learn more. So thank you so much, Dr. Danylov. We really appreciate for this presentation. Now I think we can move forward. Like we need to also recognize our sponsors. That's Greengold Estate. I'm sure on the doctor's email, we received some of the promotion that are going on through the MOU that is between Greengold Estates and Zambia Medical Association. So at this point in time, allow me to introduce Madam Kalunga Ngulukila, who is the head of sales and marketing, to take us through what products that they have for the doctors. Madam Kalunga Ngulukila, you're most welcome. You can take it up.
Good evening. So apologies, Mr. Simukoko wasn't able to join us for this presentation this evening, so I'll be taking over. And so as introduced, my name's Kalunga Ngulukila. I'm the head of sales and marketing at Greengold Estates. Let me just share my screen. Okay, so I'm going to take you through our products and services this evening. To start with, as mentioned, we did sign an MOU with the Zambia Medical Association. So this MOU does come with certain advantages. Ideally, it comes with immediate access to land. So all ZMA members are now enjoying immediate access to land immediately after the first deduction. The other advantage this MOU has is obviously, these plots now come at a discounted rate because we are stretching the payment plan to about 72 months. So I'll briefly start with introducing our company. So Greengold is a property development company We were established in the year 2022. Our vision is to be the leading estate agency in Zambia, recognized for expertise, integrity, and commitment to excellence in all aspects of our work. So other than just the Zambia Medical Association, we have signed a couple of MOUs with other organizations. We're servicing over 1,000 clients as of today. So the other MOUs we've signed are the Zambia Air Force, the Zambia Correctional Services. We do have the PEMIC code, so we're able to cater for all civil servants in Zambia. We've signed with Auxiliary, with PricewaterhouseCoopers, with British American Tobacco, and with NUPES, which is the teachers union. Currently, we have 8 sites. We actually introduced our newest sites this week. So we have 6 sites in Lusaka. We have 1 site in Central Province and 1 in Southern Province. So other than the selling of land, which is obviously our core business, we do have other services. So today I'll walk you through our sites and our services. So the first service we do offer is construction. So when it comes to construction, we do the consultation, we do the architecture design, and obviously the building itself, we do the building. So what you're seeing on my image is actually the entrance of our estate in Mikango. So that was done by Greengold. We also have conveyancing, which we do as a service. So for conveyancing, we do the title acquisition and the due diligence. Not to mention all our land that we're selling at all our sites is titled. We also have House Avocado farming services. So for those who are not familiar, House Avocado is a creamy, flavorful avocado, which is widely sought out for some benefits it has, which is the high oil content, the long shelf life, and the high nutrition value. So with the House Avocado, we do an outgrower scheme. So on our outgrower scheme, what we basically do is, if you have land, it can be anywhere in Zambia, we're able to plant. We'll bring our professional agronomists to do a consultation. So we'll do the soil sampling, we'll access this land, and we're able to plant. After we plant this House Avocado, we're able to offtake. So we also do seedling supply. We're selling seedlings for House Avocado. So we sell these seedlings for 120 per tree. And as I earlier mentioned, we also do the consultation. So we're able to sign offtake agreements. We do have rather an estate where the package is inclusive of this House Avocado. But like I've mentioned, even if you don't have, even if you have land elsewhere, we're still able to do this as an outgrower. We do supply and installation of drip irrigation systems. We do the farming services and the seedling supply. So this is under our House Avocado. So if you look onto my screen, I'm just showing the revenue out of the revenue one is able to get out of this House Avocado. So I'm going to use 80 plants, which will be planted on a 0.5 acre portion. So this is like half an acre. So the House Avocado matures after 3 years. So if you look at one House Avocado tree, it's able to give you about 200 fruits. So you're able to get about 16,000 fruits if you do these 80 trees, and you're looking at an income, or rather a revenue of 96,000 annually. So this is in year 3. If you look at year 5, obviously this tree has matured. Full maturity is at 3 years, but if you look at year 5 or how house trees work, as the tree grows older, you get more fruits. So at year 5, you're looking at 400 fruits per tree. So the total fruits will be 32,000. You're looking at a revenue of 192,000. So the lifespan of a house tree is about 25 to 50 years. I'll now walk you through our 8 sites. So our first site is Acacia. The pictures are showing Acacia Estate. So this is located in Mikango, which is off Leopards Hill Road. It's about 30 kilometers from the Crossroads Mall. and 21 kilometers from the state road junction. So here we have Acacia, which is a gated community, which is comprising of 30 by 40 residential plots. And this estate is exactly 800 meters from the tarred Leopards Hill Road. So we have opened, graded, and compacted the roads. You'll be able to see this when you're on site. We have Pine Gold Estate, which is our only agriculture estate. So this one comprises of small holdings, which are 3 acre in size. So the Pine Gold is located in Mikango as well. It's 30 kilometers from Crossroads and 21 kilometers from the State Road Junction. So here, like I mentioned, we have 3 acres, which are small holdings. So this is the estate we have that comes with the Hass Avocado package. So you're looking at 80 trees. For every 3 acre you buy, we give you 80 trees of the Hass Avocado. We drill a borehole for you and we give you a solar pump. So all this is part of the package. And then once this Hass Avocado matures, we do offtake. So we get into an offtake agreement. Our next site also in Lusaka is Stable Heights, which is in Shumavala. So this one is 32 kilometers from CBD. And then it's 3 kilometers off Kafue Road. So we have 30 by 20 plots here. And obviously you do enjoy the flexible installment plan here of up to 72 months. We also have Mabuyu. So Mabuyu is our estate, which is in Livingston. So this one is located in the Kasie area. So if you're coming from Lusaka, it's after the toll gate. But if you're coming from Livingston, it's before the toll gate. So it's in Kasie resettlement area, 14 kilometers from Livingston town. So this one has a standard of 30 by 20 plots as well. So all the images that are showing on the screen are actual images of all our sites. So we have open, graded, and compacted the roads in this estate. We have Musuku, which is our estate in Kabwe. So this is 13 kilometers from Kabwe Road. It's in an area called Natuseko Small Holdings. So here we have a standard of 30 by 25 plots, which is 750 square meters. So we have opened the roads on site as well. Then we have 2 sites in 21 miles. So we have Lantana Annex, Lantana Gold, and now the newly opened Mubanga Gold. So we have 3 sites in 21 miles. So with Lantana Gold and Lantana Annex, these are standard 30 by 20 plots. That's 6 kilometers from Great North Road. We have opened and graded the plots on site. And finally, our last and newest site is the Mubanga Gold Estates, which is also in the 21 miles area. So this one has a standard of 30 by 20 residential plots. Then as part of our independence promotion, after a promotion, so ideally these plots, I'll just switch my screen to the plot prices. I did realize I didn't share the prices. If you look at our plots in Shimavala, the ones that are 30 by 20, the plot price is 90,000. The payment plan is stretching up to 72,000. Oh, sorry, 72 months. So at 72 months, you're looking at a monthly of 1,250,000. Then Lantana Gold and Lantana Gold Annex in 21 miles. The plot price is 45,000. So you're looking at a monthly of 625. Then Musuku in Kabwe, which is 30 by 25, the price is 60,000. A payment plan of 72 months, you're looking at a monthly of 833,000. The site in Livingston, which is Mabuyu, plot size is 30 by 20. The plot price is 60,000. Under 72 months, you're also looking at a monthly of 833. Then Acacia in Mikango, where we have the 30 by 40, the price is 290,000. With a payment plan of 72 months, you're looking at a monthly of 4,027 kwacha. Then Pine Gold, which is our agriculture estate that has the 3 acres. The plot price is 850,000. The payment plan of 72 months, you're looking at 11,805 monthly. And finally, Mubanga Gold in 21 miles. Plot price is 50,000, payment plan of 72 months. You're looking at a monthly of 694. So as I earlier mentioned, we're also running some promotions. Our independence promotions is on 2 sites. We have on our newly opened Mulenga Gold site in 21 miles. So the plots have been slashed from 50,000 to just 35,000 on cash basis. And then our Shimabala plots as well. The plot price is 90,000, but on cash basis during this independence period, they are going for 50,000. And Livingston, our plot price is 60,000, but for independence, we've slashed them to 50,000 on cash basis. And finally, our Kabwe site as well, the plot price is 60,000. For cash, we have slashed them to 35,000 as well. I've come to the end of my presentation. I will take any questions and thank you so much.
Madam Kalunga, are you done?
Yes, I'm done.
All right, thank you so much for your presentation. Now I'll give chance to the members. If they have some questions or some clarification, please, over to you, those that have questions. If I can't see your hand, you can just unmute yourself and speak.
Evening.
Good evening, thank you.
Yeah, this is Dr. Mawa. I just wanted to find out, so when can we visit the sites, like the sites where you have the plots? Do you have specific dates and so on?
Okay, so ideally we have site visits every Wednesday in the afternoon and every Saturday in the morning and Sunday in the morning. But you can always reach out to us at your convenience and maybe we can be able to arrange, because if we have demand, we do go to site.
All right, thank you. Or do you have an outline or something? Or do you have to go to your website or something?
Okay, no, our contact details for our company phone is 0975 519 871. 0975 519 871.
Just go through the number again.
0975 519 871. 0975 519 871. Or you can also email us at info@greengoldZM.com. info@greengoldZM.com.
Thank you.
So also, I think I didn't mention during my presentation, so our land is titled and we give up to survey diagram. But also, as I mentioned in my presentation, we do conveyance, and so we're able to do that for you as a service, if you want us to help you process the survey diagram into title.
Okay.
Madam,
Okay,
the
any
last
other
one, is this
questions?
line on WhatsApp?
Yes, it is on WhatsApp.
All right, thank you.
I've just seen a question saying, is it possible to post our contact details on ZMA platform? So I'll be able to do that. I'll share them.
Do we have any other questions from the doctors? Looking at time, I think it's very clear. We would love to thank you once again, Greengold Estate, Madam Kalunga Gurukila, for your time. And we wish that the products that you are offering the doctors who have interest and find time to contact you personally so they get some more information and see how best we can run together in terms of acquiring of land by the doctors. So once again, thank you so much. And thank you everyone for your time. I'm sure we've learned a lot about tranexamic acid issues and also from Greengold about the land. We wish you all the best and we'll meet once again once something new comes up. Thank you so much. Bye-bye and have a lovely evening.
Thank you.
Bye, Charlie. Hello.